CAA is a good medical expression that stands for cerebral amyloid angiopathy. So to kind of parse that out, so the cerebral part means in the brain. Amyloid is probably the key word there. So amyloid is the stuff. Amyloid is probably a garbage product that, as far as we know, doesn't have an actual function in the brain. It's meant just to be thrown away. But in people, as they get older, it will build up. And the angiopathy part, the angio prefix, refers to blood vessels. So it's amyloid that builds up in the blood vessels of the brain, particularly in people as they get older, and can either do nothing, can be a small and harmless amount, or it can be enough to cause problems with the blood vessels. And those problems can be either that the blood vessels don't work properly, that they don't supply the brain properly with blood, or that the blood vessel walls become weak and break open and bleed. Those are the two things that we worry the most about with CAA. Yeah, some of that CAA probably happens in close to 100% of people if they live long enough. Again, in most of those people, we don't recognize it as doing any damage, and it probably doesn't in the majority of people who have some of that deposit, some of that buildup. But in a pretty substantial minority of people, it gets bad enough to cause at least small amounts of bleeding in the brain, and probably small amounts of damage in the brain. And as it becomes more advanced, those are the people who we recognize have worse cognitive function, even above and beyond what they would get from other just aging or Alzheimer's disease or other problems like that. And then another proportion of people get bleeding strokes. And in our hands, it's probably the most common, or just even with high blood pressure, as the most common cause of bleeding strokes in people as they get older. The question of how many people it affects is not an easy one to answer, because it sort of depends where in the, if you think of it as the tip of the iceberg, you know, where in the iceberg you begin to say, well, this is causing trouble. If at the smaller end, the most severe end, something like 20% of all strokes are bleeding strokes. And on the order of half of those are especially in older people, related to amyloid angiopathy. So that's a minority of strokes, but still a minority of a pretty big number, because strokes are a pretty common problem in the States. They've now gone down to the fourth leading cause of death, strokes in general, and still the leading cause of disability. So even 10% of that is a lot. At the kind of larger end of the numbers, actually good data from the Rotterdam scan study, a really excellent study where healthy people undergo MRI scans. Something like a quarter of the people over 65 in Rotterdam have tiny areas of bleeding, what we call microbleeds. And not all of those are from CAA, but many of them, possibly most of them, are related to CAA. So those are people whose CAA is bad enough to cause a vessel to become at least a little bit leaky, to allow blood to leak out, and possibly to cause other damage as well. So it's somewhere in that ballpark between being a small but still substantial cause of stroke and potentially a much larger contributor to cognitive impairment. We spent a lot of time thinking about this question of how many people, to actually put a number on it. And if we talk about bleeding strokes in the States, that would be in the tens of thousands each year. And of course, worldwide, this is not just a problem in the developed world. It's also people in the developing world are living longer, not dying from as many childhood diseases. So stroke in general, including bleeding stroke, has emerged as a bigger problem in the developing world. And in Asian countries, bleeding stroke rivals non-bleeding stroke as in terms of frequency. So none of these numbers are small. And then again, if you start to talk about 20 to 25% of everybody, well, of course now you have a number in the many millions. And again, that's probably a little bit of an exaggeration, but it gets the idea that this is not a rare problem. Really, it's been slow to come on to doctors' radar screens, that it's a problem that even many physicians, even neurologists will say, well, I'm not sure what that is, or that's very rare, and we know that's not true, and it's been gratifying to see over the last 10 or 20 years that it's gone from being sort of a curiosity of, a once-in-a-lifetime diagnosis for a doctor to make to something that is recognized much more commonly now. So the connection between Alzheimer's disease and CAA is very strong at sort of a biological level. And what I mean by that is that the amyloid in CAA is essentially the same amyloid as the major player in the plaques that form in a brain in somebody with Alzheimer's disease. So at the molecular level, these are very closely related. The two pathways, though, clearly go in different directions at some point, because the majority of patients we see with CAA do not have dementia when they come to us, don't have the kind of memory loss that would be diagnosed as Alzheimer's disease, and the reverse of that is also true, that the majority of people with Alzheimer's disease don't get the kind of bleeding that you get in CAA. So at some point the two differ from each other. Having one is not a sentence that you're necessarily going to have the other, but I think it's pretty clear that anything we learn about one of the diseases will help us treat the other one. So I don't think CAA causes Alzheimer's disease, or Alzheimer's disease doesn't cause CAA as far as we can tell. But the two can overlap. I think when we see them overlapping, it means that amyloid is depositing in both places. So they share some risk factors. They even share some genetic risk factors. So you can see the two coming side by side. They often happen that way. But for reasons we don't completely understand, often you'll see one of them stepping to the front and being the main problem, and the other one more in the background as a minor problem. I think very often our patients have just one or just the other, at least as far as we can tell. If we looked at their brain under a microscope, it might be that we would see some Alzheimer's disease in our patients who we think have CAA, or some CAA in our patients who we think have Alzheimer's disease. But the most common situation is a CAA patient who does not have Alzheimer's disease, or an Alzheimer's disease patient who does not have CAA. And I always make that point when I see patients. They often will do a little bit of reading and say, oh, if I have CAA, it means I'm definitely going to get Alzheimer's disease. And that does not seem to be the case. Bad enough CAA, again, carries two risks with it. One is the bleeding stroke, and the other is cognitive impairment or dementia. And we're getting better at predicting what the future will happen in patients, but the prediction is still difficult to do with certainty. And of course, our real goal isn't just to predict what will happen, but to be able to change it and be able to make that risk of either bleeding or dementia go as down as much as possible. We would love to prevent it before it happens.